Hi, my name is Teresa Brannon. I'm the manager for the Training and Technical Assistance at North American Management. I am pleased to announce the beginning of the webinar for strategies for effective board governance in health centers, and I'm happy to start introducing our panel today. David Vincent is the Deputy Executive Director with the DOOR. In his current capacity, he is responsible for direction and leadership of a continuum of services targeted at the social, mental, and personal development of some of New York City's most vulnerable adolescents. Additionally, Mr. Vincent is responsible for the agency's program expansion efforts and enhancing the organization's ability to integrate, deliver, and measure its services. Prior to joining the DOOR, Mr. Vincent was the Associate Executive Director of Callan Lord Community Health Center in New York City. He was responsible for the development, implementation, and oversight of population health condition-specific services, including HIV services, women's health services, mental health, oral health services, adolescent health services, and health education. Mr. Vincent is responsible for adherence to government funding requirements and regulatory. He also served as Family Health Centers of San Diego's Assistant Director of Special Populations and Mobile Medical Services. And moving on, Mr. Allan Citron-Salichs is the Executive Director of the Centro in Puerto Rico. It is one out of 20 health centers across the island. And Ms. Karen Williams is the Director of Public Housing Primary Project at the West End Medical Centers. The webinar today, Mr. Citron-Salichs, Mr. Vincent, and Ms. Williams will focus on strategies for effective board governance in a primary care program health center. Topics will include best practices, member outreach, member retention, and governing board requirements. Mr. Citron-Salichs and Ms. Williams will share some of the challenges and lessons learned with board governance. And I turn it over to David Vincent. Thank you.
Great. Thank you so much, Tricia. First of all, I'd like to thank North American Management and the National Center for Health and Public Housing for inviting me to lead today's webinar. And also I'd like to thank HRSA for their continued support to educate our community health centers and public housing primary care projects throughout the country. Today's workshop is to discuss the issue of governance. As you know, the issue of governance continues to, I'm sorry, there we go, tiny technical problem. The issue of governance is the process in which consumers and non-consumers participate in the oversight of health center operations. Why is this important? You know, community health centers throughout the country, as part of our mandate through HRSA as a requirement to receive funding, we are required to have consumer feedback into our operations of the health center. And this couldn't be more critical. As you know, we have 19 very important programmatic requirements, 3 of which are tied into the issue of governance. So this is an issue that really is critical to all community health centers to really figure out how to do it and how to do it better. And you know, we couldn't be more lucky to have 2 really brilliant health centers, the health center in Ponce, Puerto Rico, and the health center in Atlanta, Georgia, who are really some of the best health centers in the country, and we're lucky to have their words of wisdom with us. So we have both community health centers, some public housing authorities, and some board members on today's call. So I'm going to try to make this as general as I can and go into more specifics when possible, but we do have a very diverse audience, so I do need to do some foundational stuff to make sure everybody gets some of the basic knowledge of the governance requirements for HRSA. So when we look at what the federal mandate is regarding board compositions, health centers must have a majority of individuals that are part of their board. A majority is 51%. If you have 9 people on your board, that means that 5 of them have to be consumers. Pretty basic understanding that. And When you are defining your board of directors and the board composition, the individuals must be consistent with the race, ethnicity, and gender of your intended community. So, for instance, I worked in San Diego with a community health center, very Latino community. As a result, we had a very large representation of Latinos on our board of directors. The HRSA has some mandates regarding board size. Must be a minimum of 9 individuals and a maximum of 25 individuals. Additionally, of the ones that are of the 49%, so these are for the non-consumers, no more than 50% of those individuals derive more than 10% of their income from the healthcare industry. So that's an important note to make sure that you double check when you are defining your board. Additionally, it's important to know we have several grantees throughout the country that have funding from both 330E, 330H, 330I, and 330G. And what does that mean? How do they deal with meeting those board requirements? HRSA has given us some recommendations on how we do that. So if you have a public housing primary care project, in addition to your community health center funding, 330E funding, you're required to meet your 51% of consumers, and then second, you only need 1 PHPC grantee to represent that project. Similarly, if you have PHPC and healthcare for the homeless, you need to have 1 PHPC public housing resident and then 1 healthcare for the homeless, 1 homeless representative on your board. If there's questions on that, we can talk a little bit more about that at the end of the call. Additionally, the board composition requirements that HRSA has mandated do not apply for those Indian tribal organizations who receive funding. So they are exempt. One thing you'll notice from this slide is there are tiny little asterisks at the end of them. And what do those mean? So those actually mean that for those projects that only receive 330H or 330I funding, that means that they do not receive 330E funding, that there is some flexibility in how board composition is defined. Again, remember, this is only if they solely receive 330H or 330I funding. So if you receive 330E funding and 330H or 330I, or even interested in just receiving those, you have to continue to meet the board requirement regarding board composition. Moving on, what if you are having some challenges in defining who your board is? There is a process of, while in some communities it might be hard to obtain a 51 consumer representation, and it really is possible to do that. They're not granted automatically. It is a process. I believe it is Form 6B. You could talk to your HRSA project officer regarding that component. It should be noted that, that this is really a requirement, and when you're applying for it, you really have to be you have to go into a lot of detail about why you are requesting that waiver and how you are unable to meet that. There'll be a section on that to say how you will meet that. So your obligation to continue to have consumer feedback and representation in the operations of your program will need to continue. Your application 6B will need to note how you will be going about that process. An important thing about waivers, typically waivers are granted only for 2 reasons: that someone is not able to meet their 51% consumer representation, or they're unable to meet the monthly requirement. As I shared a little bit earlier, you'll need to provide feedback into how you're going to get, you're going to need to provide detail on how you're going to provide feedback to how consumers will be participating in the operations of your health center. And historically, waivers have only been granted for 330G projects. It's pretty hard to get a waiver nowadays, if you ask me sort of off the record, but on the record. They're very, very difficult to get. And the requirement from HRSA is that you figure out how to do it. And hopefully today we'll learn a few more strategies. But a waiver is possible. Their waivers tend to be granted more often about the monthly meeting requirement. I haven't heard too many projects throughout the country get waivers because they're not able to meet the 51% of consumer representation. Really about meeting the monthly meeting requirement, and you really need to provide detail on how that meeting requirement could be best met if you're requesting a waiver. Going on, what are the other board requirements? The board requirements are, again, that they meet at least once a month, and that they select the services that are provided by the health center. Additionally, they need to determine the hours of operation that services are going to be provided, whether it's just regular 9 to 5 service hours, or whether there's late evening hours, weekend hours. All of those different components are defined and determined by the board of directors and approved by the board of directors. Additionally, the board is required to measure and evaluate the programmatic and fiscal goals of the agency. So it's really keeping track of the agency's budget, approving the budget, and continuing to monitor that throughout the course of the year. Additionally, the board of directors develops and approves the agency's strategic plan. HRSA really hasn't set forth mandates on how often that happens. I think that there are some best practices that should guide health centers on how frequently strategic plans should occur. I think most people think it's about 3 to 5 years, probably closer to 3 years. Most people nowadays believe that when you do it closer to 5 years, some of the information you get might be a little up to date with such a changing economic environment. Additionally, the board of directors is responsible for reviewing the health center's mission and bylaws on an ongoing basis. Pretty self-explanatory on what that is. Additionally, health centers need to have a conflict of interest policy. This must be noted in the bylaws, and the board must sign off on this conflict of interest policy. What does that mean? The policy must prohibit, and these quotes are directly from HRSA, so it must prohibit conflict of interest by board members, employees, consultants, and those who furnish goods or services to the health center. It's probably wise when you're developing your bylaws to actually make sure that you include that quote, to make sure that you're actually compliant with the mandate on the conflict of interest policy. Board members cannot be employees of the health center. Additionally, board members cannot have an immediate family member that's an employee of the health center. So if I was married, my wife or husband could not be an employee of that health center. Additionally, the executive director and CEO can only serve in an ex officio member capacity on the board of directors. When we're looking at, oops, somehow this slide got out of place, so please forgive me. This is back on the board requirement piece. Additionally, boards must evaluate patient satisfaction on an annual basis. Many health centers do this differently, ranging from an actual paper satisfaction survey that gets distributed throughout the year. Some people do focus groups, some people do a combination of both, but we are required to, the board is required to make sure that patient satisfaction is checked on an annual basis. As I shared earlier, that boards of directors are responsible for approving the annual budget and following it throughout the year. They are responsible for approving grant applications. Nowadays, it's not uncommon to require an actual signature from the board chair on a grant application in the initial submission of a proposal. Additionally, board members must approve the selection and of the health center's executive director and chief operating officer. They must review on an annual basis the performance of the health center's executive director or CEO, and that performance evaluation should be kept in human resources in their personnel file. The board of directors is also responsible for approving the general policies of the agency's just general policy and procedure manual. They don't have to, this is more so in regard to human resource policy and fiscal policy and confidentiality. I don't think that the intent is really for every programmatic policy to be approved by the board of directors, but really the pretty significant ones that fall underneath the purview of the board of directors. Moving on, where is the flexibility in how this all happens? So the flexibility is really about public centers. So those agencies that are run by a public university or some type of municipality, there are certain flexibility components of the board of directors, and they should go to the HRSA website, but please know that there's some flexibility on how those are determined. The big key points are the approval of personnel and fiscal policies. There's a little bit more flexibility than those health centers that may not be public, quote unquote, centers. Additionally, as I shared earlier, that there is some flexibility in sometimes about the monthly meeting requirement. Granted, that is not an automatic assumption that there is flexibility of that. The mandate from HRSA is that the board of directors will meet on a monthly basis. This can be an in-person meeting, a conference call, but it still has to be a formal meeting that minutes are taken and the key issues are reviewed. When we're thinking about public housing residents, those who have public housing 330 funding, the requirements are to have 51%, if you just have solely 330E and 330I funding, so general community health center and public housing primary care. The objective, again, is for you to have 51% consumer representation, but when you're thinking about who makes that public housing resident, so this is the definition of what a public housing resident is. Those who apply for PHPC funding know this very well because this was included in their application, but those who are interested in applying for PHPC funding, this is something important to know, that the Act includes low-income housing developed, acquired, or assisted by a public housing agency. So a public housing agency is your local housing authority. What this does not mean is Section 8. So those individuals who receive Section 8 vouchers do not fall under the definition of public housing resident. So this, at this point, this means individuals who received project-based vouchers or gosh, I'm sorry, I forget what the other one is. Karen will tell me in a second when she comes on. But there are two different types of Section 8 vouchers, and neither of them do fall under the definition of public housing. So it really is low-income housing that's run by the housing authority. Member outreach. So when we're looking at recruiting new members typically has been a board-driven process. The executive director has always had a very pivotal role in identifying these individuals, whether it's just her walk through the health center, seeing really engaged community members and outreaching to them, or whether it's their participation in local community meetings. they oftentimes do make their first point contact and then refer them over to individuals on the board who might be in charge of recruitment. Additionally, a good executive director is always on alert for board members who might, potential board members who might be good matches for them. So it is really a 24/7 process. I'm sure Karen and Allan will tell you it really is a never-ending process. A lot of the PHPC projects that are out there really use their program staff for referral sources. So they know who in the public housing complex that they're working with, who's an active member of the public housing community, and who might be someone to participate in. So those that are searching for a public housing resident to participate on their board, I encourage you to really talk to your line staff to see who they know in the public housing community are leaders and who might potentially be good matches for the agency's board of directors. Additionally, working one of the pieces, and Karen will talk a little bit about this, is every housing authority throughout the country is required to have a resident advisory council. And this is a 100% consumer advisory council. So they provide feedback into the local housing authority, into the operations of their community. This is an excellent referral source for potential board members, and I cannot stress it enough. I know that Karen got one of their fabulous ones from their resident advisory council, so she will tell us more about it in a few minutes. Additionally, really about thinking outside of the box and looking for potential board members. There are some community health centers that are affiliated with local Head Start programs, and those provide great feedback, or local church organizations or Girl Scout organizations. They provide really wonderful opportunities for community members who are already engaged, who may be looking for some additional opportunities to be involved in their community. Additionally, it's really important to think about, you're only required, if you have 330E and 330I funding, to have one PHPC representative. But I really do encourage individuals to explore having more than one person. And why would you do that? Because public housing communities are very, very diverse. So I ran a public housing project, public housing primary care project in San Diego. And we had the diversity of our public housing projects was absolutely amazing. We had one that was just seniors, and we had one that tended to be more families. It was closer down to Tijuana, so it was more Latino families. Then we had one a little bit north that had much more diversity of some recent African immigrants. So if we just had one public housing representative, we probably would miss the full opportunity to have a much broader bit of feedback from our public housing residents. So I really do encourage you to do that. And both Karen and Allan can tell you more about their individual members. How do people keep members? Because this is really a very, very critical part. Incentives really do increase participation. We know this about whether someone participates in a survey or whether someone participates in a study. People like to get incentives to participate. However, we can't, one of our requirements or guidelines from HRSA is that we can't provide direct monetary incentives. So, Susie is one of your board members. We can't give her $50 every time she comes to a meeting. That, unfortunately, we can't do. But what we can do is we can offer a couple of different things. Food is a big thing. Most boards of directors do offer the opportunity to provide a meal. But there are some agencies that do that a little differently. So there's an agency, I believe, in Massachusetts that orders a little extra food for the board meeting and allows the public housing representative to take the extra food back to her community. And she places it in one of the big resident areas and uses that opportunity to talk to her community members about what is happening at the health center. So not only does it get that member to the meeting, it provides her some food, she gets to go back to her community, bring food, but also it serves as a tremendous outreach to that public housing community where she's engaging community members about the activities of the community health center. Many board of directors throughout the country do offer child care. This can be done a few different ways. Some have formal arrangements with local nonprofits to provide child care for their board members when they come, whether it's a consumer or a non-consumer, who come to meetings and have child care issues. Some have informal relationships with community organizations and allow for children to be dropped off while mom attends or dad attends a meeting. And some figure it out internally and might have programmatic staff watch their child during the meeting. Additionally, conference calls are a wonderful way to retain members because getting to a meeting can sometimes be challenging for people. So having the opportunity to participate in conference calls and people to call into conference calls is a great opportunity to continue to increase membership. A note to consider is that a lot of individuals only have cell phone usage, cell phones now. So if you're going to have an hour conference call, you do need to take that into consideration that someone may have limited minutes on their calling plan. So if you're having a 2-hour meeting every other week, that's going to take a lot of minutes off of their calling plan. And you can, HRSA allows for us to provide some coverage for those minutes, covering the minutes of those plans as part of the retention. Additionally, we're able to provide some funding for reimbursement. So if you pay for a car service for Mrs. Jones to come to the meeting or cab fare or something like that, that is something that's allowable and is a nice incentive to get someone to the meeting. Different projects throughout the country have provided some interesting opportunities for translation. So in making sure that individuals who are not English speaking are able to participate in the board activities. This is done in many different ways depending on the community. Some have them sit next to an interpreter who provides interpretation solely for them during the meeting. Some agencies with more resources actually have headsets on and they provide translation. Additionally, technology, the use of technology to stay in communication is a nice way to think about retaining members. As you know, those that have boards of directors, they're frequently emailing updates, board updates to board members, sending off financials and all of those different things. And some consumers and even some board members don't have internet access. So there's a project, I forget where, maybe in Texas, that actually provides iPads to their board members in a way of assisting them in staying in communication. Granted, they did not use HRSA funds for that. Now I'm pleased to turn this over to Allan and Lydia. I don't think you guys have met Lydia yet. Lydia Figueroa is one of Allan Citron's key staff people, senior managers over at the Centro in Ponce, Puerto Rico. Allan, are you with us?
Yes. Hi, David. That was a very complete explanation you gave about the duties of the board, and it was a very good baseline for all of us. The way I want to bring it up is probably from the perspective of how we do it. So to go into that, first I'm going to start, who we are. We were founded in 1971, so that's 41 years of being in business as a community health center. Today we have a baseline of 60,000 patients who last year performed 215,000 clinical visits to our center. Our target population is 292,000 people within all the people living in the scope of service area. our operational expenditures for last year's went up to $40 million. And we have 288 FTEs, 300, that equals to 315 employees altogether. We have 9 sites servicing 4 municipalities. That is 1 main center, 4 satellite centers, 4 mobile medical dental units, and we have an array of healthcare programs, including going from general medicine, family medicine, internal medicine, OB-GYN, prenatal care, family planning, pediatrics, vaccination, dental, ambulatory surgery, which is to open this year, mental health, psychiatry, psychology, Gray and White HIV/AIDS special program, and ancillary services comprise full-service pharmacy, laboratory, and diagnostic imaging. Going into the Board of Directors issue, our statutes require that the Board of Directors have a minimum of 9 members and a maximum of 15 members. A fact that is in compliance with HRSA's requirements, which requires a minimum of 9 and a maximum of 25. And we feel like 15 is a very manageable size of board members. The good news is that 100% of our voting members are consumers, patients, and therefore all have clinical records at Centro and perform a minimum of 1 visit to their clinician once a year, whereas requirements of HRSA is that it is at least 51% of consumers. The way we did this is that we urge them, to why, if you are representing a healthcare center, not becoming part of this health center. However, we are able to do this because we are a 330E, 330G, and 330H health centers, so they all qualify for receiving services. Whereas if you have a board composition from, let's say, public housing, you're only serving public housing, that might be a little bit more difficult to attain. Our governing board of directors encompasses 14 voting members, and 2 of which are ex officios, and that's me as executive director and the corporate attorney, who is always sitting in the board and providing his legal counsel. 10 of the voting members, that's 71%, are non-professionals. That is a retired teacher, artisan, an HIV patient, a member of public housing, and in fact, she happens to be the president of the Resident Advisory Committee, and that's in our area, that's the biggest housing complex. We have a student mother, a farm worker, a lab technician, a maintenance employee. We have a port employee, another artisan, and 4 professionals. And those professionals bring kind of a balance, but they are also consumers as well. One is a CPA, one is an education doctor, one is a business administration doctor, and the other one is a physician. About the ethnicity, well, here in Puerto Rico, that is not a problem because 99.9% of residents in the island are all Latinos, so that's pretty much covered there. About the board recruitment process, we have various sources. By invitation of current board members, they've been, as you said in your presentation, David, we are always in the search of new candidates. We have quite some people in the pipeline to be admitted as members of the board. By referral of field staff and of patients that demonstrate to have interest in development and organization, and that they represent the special populations that the board needs to have represented. And by scrutiny of citizens that may provide an area of expertise to the board, and that is the case of the professionals we have sitting in the board. Now, a rule of thumb that has worked is that all member candidates are scrutinized by the board selection committee regarding their personality characteristics as to assure that there is a cultural compatibility. And that's a problem we have observed in other boards, that you might bring somebody in who might be, might be very knowledgeable, but might be most of the time a dissident of bringing forth, the important issues of the board. So, and that happens, we've observed that much to happen when you bring into the board politicians. They kind of have their specific agenda. So the board of directors, is very concerned about, who they bring in and their cultural compatibility. Now, from our point of view, what a board member gets? Well, first of all, a high degree of satisfaction for their volunteer work. We make sure, they build pride on what they do. And we like them to spread the news in their communities. A proactive participation in the meetings. All are urged to bring their ideas and to talk in the meetings. They also get a thorough monthly report on the operation. As executive director, I not only bring the facts, but I bring the facts in a way they could understand, they could all understand. For instance, the analysis of all interim financial statements on a monthly basis, they are brought on a graphical manner. So if our net assets are going down, they can see the trend, and they can easily ask questions. Why is that going down, or why is that going up? So we provide them with much information. Also, all our meetings end up with a family-style meal. We meet at 6:30 in the evening, and by the time we end, it's normally 9 o'clock, and then we have a meal all together. And that has helped a lot into bringing more rapport among members, into not feeling alienated at the meetings, and you kind of make the board work like one team. Members get a monthly stipend. It's the same for all of them. $50 a month if they make the monthly meetings. That's to cover all their expenditures of transportation, communication, whatever it is covered there. It's a fixed amount, and only if they make the monthly meetings. Board members also wear a corporate ID card. Whenever they come to the center, they are wearing that card. So everybody knows and recognizes and acknowledges, that they are board members and that they are working for them, for all the employees and for all the patients, on a volunteer basis. Board members are actively involved in extracurricular activities. We do many extracurricular activities throughout the year, and they're all invited, to participate actively. Board members are not, and in fact, they do not are required to intervene in administrative tasks. They're not required to do so. They're provided with transportation whenever they can have it available. And as said before, there's huge pride and recognition among them. Board members are actively involved in the quality program of the center and the satisfaction of patients. One important thing that we would like to bring up is that there are rules of engagement between board and administration. And we believe this to be a core point to which we have to look at. It's very easy to cross the line between direction and administration, and unless you really talk about and what belongs to who and when. So board of directors are required to look at policies, legal decisions, institutional ethical behaviors, capital expenditure decisions, budget approval, funding applications approval, strategic direction of the corporation, whereas administration looks at regulations of the policies, legal negotiations, complying with institutional behavioral expectations, administrative and operational endeavors, identification of funding sources, administrative decisions, decision-making, and the chain of command. Our board members do have certain requirements they have to meet. First is a serious commitment with attendance and participation at the meetings, ethical integrity. Some are required to represent special populations, and they are always required not to cross the line of direction to administration. We believe that among those, there is the most important requirement that we have to look at whenever there is some members being considered to join the board of directors is the passion they put to being a board member. Our rate of absenteeism in the board is very, very low. We usually have full attendance most of the year. When they are not attending most of the time, it's either because they are sick or because they are traveling. But other than that, we have attendance. In fact, they keep calling, to make sure, the meeting is going to be held, the day and time it was set to be held. So we are very lucky to have a very, very good board. But I think it's not just part of speculation, is that we have worked very closely and we have defined the fields of action. So there is no overlapping of functions. We believe that to be the key component of having a very healthy board. And they bring in, a point of view that because we are, as we say, because we are in the forest, we can't see the forest. They bring that outside look and that inside look that we don't look because we're in the everyday, running with the business. So,
Allan, I'm
yeah.
sorry. We still got Karen, so can we just keep some of this last part for the question and answer period?
Sure do.
Yeah.
I just ended my part. Yeah.
Oh, perfect. Thank you. I'm sorry for interrupting you. Please forgive me. I could have listened to you, and I talked far too much at the beginning, so forgive me.
All right.
So I want to just sort of quickly head over to Karen. Let's see. So Allan talked a lot about this stuff. I'm going to skip this slide so I can give Karen some more time. Karen, are you with us?
I am.
Okay,
Hi,
good.
everyone. David and Allan, you guys were most thorough. I'm kind of bringing up the rear here with the exception of the question and answer, but you guys have been most comprehensive. So I'll just share with you a little bit about West End, how we have engaged the public housing primary care resident as a member of the policy-making board here at West End. West End Medical Centers is a FQHC, Federally Qualified Health Center, for 37 years. We have been a public housing primary care grantee for the last 21 years. In that, we have focused directly on residents that live in public housing. And we have set up our facilities where we're on-site in public housing communities, and with David, I know you're going to talk a little bit about this on the redevelopment, but we may also have sites, or we do have sites that are nearby, meaning that we're across the street while redevelopment or construction is going on. But there are a number of assets to having a public housing resident on your board, and mindful that it is a policy-making board. That way they become advocates, and also to inform you of the pulse of the community, so the feedback goes both ways. One, on the seat of the board, they're able to share from the community level some needs or concerns that there are, and then there's also where it's taking information back into the community. So it really works both ways advantageously. As far as the type of responsibilities. There are a number of ways where the responsibility goes, and it can be on committees or advisory capacity in the community, in that so it works both pre and post. On the front end, we have advisory committees from the community that relates to our board, and its makeup is very diverse. There are even students that are on the advisory committee, high school students, college students, and so that information is shared at the advisory level and then taken back to the board. And then the board is divided into several committees, and the representative from the public housing community can serve on any of the committees, be it the finance committee, personnel, clinical, fundraising, program committee, any of those that that representative feels they can make their best contribution to. When we look for someone to be nominated from the public housing community, we look at in a sundry of means, and I think you elaborated a little bit on that earlier, David. It can be from referrals in the community, it can be from staff, it can be self-nominated, but we take that very seriously, and our community representatives also take that very seriously, because it becomes an opportunity to create changes in policymaking that impact your community. And when I say policymaking, we're talking the hours of our operation, closing, opening, closing, even the days. Do we open on the weekend? Type of events that we will have in the community, fundraising, and what we want to earmark that for in that particular community. So it's something that is coveted and taken very seriously because it impacts the total operation of the site that's there in that community that that resident is now representing. And so when we look at the capacity to serve, we look at a number of things. One, we also want someone who has been active already in the community, either serving on their organizational structure or has been active in the community through other nonprofit agencies or collaborative partners, whether they have been instrumental in garnering the entire community with new changes or developments that are needed, and has worked well with the housing authorities that we work well with. So there are a number of things that we really look for, even though nominations can come from a varied way. Those nominations then are taken back to the board for the board to make that selection or choice. Now, there have been a number of successes and challenges. Success being that, as I mentioned earlier, it becomes a two-way opportunity for information to be received from the community as well as for information to be shared with the community. For example, we've had fundraising where we've actually had for example, asthma walks in the community, or we've had, I think, camp where we've gone for sending kids who had asthma problems to a Camp Breathe Easy. So things like that became a link or a tie, and often offered the many successes for, one, the continuation of programming, for the utilization of the programs that have been offered, and the buy-in from the entire community as well as collaborative partners throughout the community. Challenges that we may have had is there again, what are the expectations of the board? I think what's touched on is transportation to meetings. How can we get around that? We have monthly board meetings at one central location. So if transportation is ever a problem, we offer, if it's public transportation, we offer tokens for public transportation or some other incentive for transportation to the meetings. If it's the time of the meetings, we meet in the evenings. We also provide meals, and we have dinner at 5 with the meeting to begin at 6. So if there's ever problems with or challenges relating to child care in the evening, we try to make accommodations. Our center is usually open, and we have areas that are designated for children that can wait with monitoring of staff. So there are a number of ways that's on an individual basis that we try to prevent any barriers that may prevent that voice from the community actually having a seat on our board. We are a 330 and a 330I, so we have representatives from the public housing that's necessitated, and even when that position rolls off, our board tenure is 10 years. So after that seat rolls off, then it's sought for another representative from housing to occupy that seat on the board. We have actually go over 1. We've had 2, and at one point we've had 3. So it just depends, but we also always have at least 1 seat that's reserved for a public housing resident. Training of our board members is from a sundry of opportunities. One, every time a board member comes on, they are introduced to NAC's boot camp for new board members. We have a training program on site where they are given information about what an FQHC is, how we function, how we operate, what the expectations, and as Allan, you mentioned, rules of engagement, what the difference is between day-to-day versus policy making, what those expectations are. And we also have ongoing mini retreats for the entire board and senior management. And even in that, if there are any barriers that prevent a resident from attending, sometimes I think once a year we have an overnight. And if there's something that prevents that, such as child care or transportation, then we certainly work those things out. But it's on an as-needed basis. But realizing that these are communities that are vital to our overall mission of our organization, we make every attempt to make sure that there is an exchange of information, and not just with that board member that represents, but through advisory committees that are on site, through surveys, through campaigns that are held on location. So there are a number of opportunities that support the board member that has a seat on our board throughout the community. And over the 10 years that we have had the input by having a policy-making representative on our board, it has served well as a advocate for us into the broader community. So there are a number of positives that can only be gained by having that representative on the board. I know we're close to the time, but I just wanted to also add that we also have school health initiative, and I can't say enough that children or students are vital input, even in the community, on your advisory board in the public housing communities. Oftentimes there are schools that are feeder to that community, and so students have some wonderful ideas of what they'd like to see happen in their community and in their health center, and those are valued information to be taken back to the policy-making board. And I'll conclude with that, David.
Great. Thank you so much, Karen. Both you and Allan are really such tremendous leaders in the community health center movement, and we are honored to have you guys. Thank you so much. I'm going to sort of bounce very quickly through the next couple of slides. I know people need to leave at 2, and then we're actually going to stay a little bit later for a couple of minutes for those people that have questions. And the slides will be made available, and I'll defer that to the North American staff to tell us a little bit more about how that can be shared with you guys. There are some best practices on board membership. A few projects throughout the country actually have trial membership. and someone attends three meetings, and it helps people to determine whether they're interested from a consumer level or whether the agency is interested from an agency level. In this way, it's sort of an easy out for someone that may feel like they're in over their head. Additionally, Karen spoke a little bit about this when she was talking about having students participate in the governance component. Having other grant-related programming participate in your board of directors, whether it's Ryan White funding or school-based, is really a great opportunity to look to other resources to provide feedback into your board of directors. There is a very significant change of landscape that's happening in public housing. As Karen alluded to, the Hope 6 projects are a HUD initiative that are revitalizing many communities by replacing some of the older public housing structures that have been around for 50, 60 years with much more integrated housing, mixed income housing, and that presents a new challenge in trying to figure out how to identify public housing residents. And oftentimes this process makes it very confusing for public housing residents to know if they're still public housing residents, because some of them may now be receiving housing choice vouchers or project-based vouchers and can be a little bit confused about the process. I do encourage you to continue to update your project officer, because HRSA project officers aren't always aware of what's happening in local housing authorities, so making them aware of some of the local initiatives really would do benefit. And then local resources, some really important local resources for you. The HRSA requirements is the top one. This is the pin that we all must abide to. HRSA also produced a tremendous governing handbook. This is probably a 100-page, 150-page document, which is really, really helpful. Karen alluded to NAC's tremendous work on their board training camp. More information can be found at this link, and if you're looking for more information on the Housing Act, there's the website to do so. And that sort of concludes us, and this is our contact information should you need to contact any of us. Devin, are you there?
Hi. Hi, it's
Okay.
Teresa.
Oh, hey, Teresa.
David, Karen, and Allan, thank you so very much for that. That was really enlightening. It was a great topic, and all three of you did a wonderful job in presenting the information. I do have one question, and I believe this would be more directed to you, David, because you had talked about it earlier, about the conflict of interest. Someone asked, could you please give an example of a conflict of interest by those who furnish goods and services to the health center, and how do you find out?
Yeah, so thank you. That's an excellent question. If you go to the HRSA's programmatic requirements, the 19 programmatic requirements, they'll give you the exact reference point to the legislation that you need to follow. But a good example would be someone works for a electronic health record software, and the agency is considering buying it, going to an electronic health record, and that software may be one of the ones that they consider. So someone may be interested in eClinicalWorks, but one of the board members works for eClinicalWorks. So there needs to be a policy in place that allows someone to recuse themselves from all discussion about the electronic health records in order to keep that as free from potential conflict as possible. Hopefully that provided a little bit of an example.
Great. Devin, is there any more questions? Are there any more questions?
That was it.
Okay. Well, I would like to thank David, Vincent, Allan, Citron-Salichs, and Karen Williams for this wonderful presentation. It was great, and we hope that to have them back again. And this webinar will be available on our website at www.nchph.org, or we will also email out the presentation and the PowerPoint slides later on today or later this week. And I am happy to announce that we are able to take registration for our upcoming 2013 Health Center and Public Housing National Symposium, which we are jointly doing this with the Community Health Partners for Sustainability, and that symposium will be June 4th through June 6th at Denver, Colorado, in the Sheraton Denver Downtown Hotel. And we are still accepting abstracts until February 19th, so please share with us your great projects that you're doing in your health centers. And if you have any questions, please contact me or any of the other wonderful staff members at North American Management, and they will be able to assist you in any training and technical support assistance. So once again, thank you for attending, and have a great day.
Yeah. Have a great day yourself.
Thank you, Allan. Thank you, Karen. Thank you, David.
Thank you. Thank you,
guys.
guys.
Thanks to you all. Karen, good to listen to you. It's always great to everything you have to say.
Thank
Allan.
you, guys.
Thank you. Allan, are you still with us? Okay.
I'm here, David, and you were fantabulous.
Oh, Karen,
Fantabulous.
I'm sorry I talked so long.
No, it was such great information. It laid the groundwork for us to come on, so thank you.
Oh, Karen, you're very sweet and absolutely brilliant, and I'm just sorry that you weren't able to talk as long as you could.
Oh, no, it was covered. It got covered, so thanks.
You are welcome. Thank you so much for joining.
Have a good one.
Okay. I'll talk to you later.
Bye-bye.
Bye. Bye.